All right, great. Well, we'd like to welcome everybody to the new 2024 Coding Guidance for FFRCT webinar. So if you signed up for this webinar and that's what you're hoping to hear about, you are absolutely in the right place. We're going to give everybody one more minute to sign on. I know it takes a second, and then we'll dive in and get started. But thank you for joining us. All right, great. So today we have several exciting topics that we're going to be covering, and you're gonna get to learn the panel of experts that are going to walk you through this. I'm very excited about this webinar. I think there's a lot of really great nuggets of information that are very practical that you can take back to your practice. We're going to talk about the FFRCT code transition that happened January 1. We're going to go through everybody's favorite topic, what did Medicare do for 2024? So a Medicare final rule summary for both CTA and FFRCT. Then there's going to be the meat of the webinar is going to be the AMA put forth guidance in CPT 2024 CPT changes at the beginning of the year around the new Category 1 code for FFRCT. With that new guidance, we're going to walk you through kind of what does that mean for your clinical practice, for impressions and other considerations. We're going to do a little bit of understanding of HeartFlow's FFRCT, as well as some really practical considerations for your team, your billing and coding and admin teams around Category 1 code transition. And then there's going to be a live Q&A. Just a couple quick housekeeping items before we get started. We know that there's going to be lots of questions that come through. That's great. We want and love your questions. Please type them into the Q&A box that you'll find on your bar at the top of the screen. We will likely be answering the vast majority of the questions at the end. We're going to leave plenty of time for Q&A, so you can type them as we go. You can also type them in at the end. That's totally fine. We'll also have a email address, reimbursement@heartflow.com, that you'll see at the very end. And during that webinar, or during that, you can also send in individual questions that you may have if you don't want to put them into the Q&A box. All right, so our panel today, you're hearing from me, Cara Santillo. I'm VP of Reimbursement and Market Access at HeartFlow, and I work very closely and oversee the teams that deal with field billing, our payer relations team, as well as government affairs and advocacy. I'm very excited to be joined by Dr. Mark Rabbat, who is professor of medicine and radiology at in the division of cardiology at Loyola University in Chicago. He also leads the advocacy arm, and I know, Dr. Rabbat, you'll have to correct me, there's a new name for the FSCCT advocacy team that you head up, so you'll have to correct me on that. We will also hear from, a little bit later in the webinar, Monica Burnett, who is HeartFlow's Director of Field Billing, and also probably the foremost expert on all the nuances associated with billing and coding for FFRCT. I've rarely come across a question that she can't answer with really practical knowledge of how it's applied within, a provider setting, whether it be in the hospital or a physician office imaging center. So, send your hardest billing and coding questions her way. She really can be a great resource to you and your team. So with that, I'm going to hand this over to Dr. Rabbat to walk us through the Category 1 code transition, final rule update, as well as the new AMA guidance for FFRCT. So Dr. Rabbat?
Thank you so much, Cara, and thank you for the invitation. And you're absolutely correct. The advocacy committee has recently changed its name to the Health Policy and Practice Committee. Um, so many of you may be aware of these former FFR-CT CPT codes. These are the T codes, the Category 3 codes that have officially been sunset as of December 31st of 2023. So the 0501T, which was the global code, which included all of the components of the services for 0502T, 0503T, which were the technical codes, as well as 0504T. Now, this requires the performance of cardiac computed tomography angiography, so CCTA, code 75574 as a pathway to perform non-invasive fractional flow reserve CPT codes of 0501T to 0504T. But as I said, these have officially been sunset as of December 31st of 2023. Next slide, please. So now FFRCT has converted to a Category 1 code effective January 1st of 2024. On the left, you see the former Category 3 codes, which are no longer in effect, and the current Category 1 code, which is CPT code 75580. Now, the description is non-invasive estimate of coronary fractional flow reserve derived from augmentative software analysis of the dataset from a coronary CT angiography with interpretation and report by a physician or other qualified healthcare professional. Now, it's important to use 75580 only once per coronary CTA. Now, when non-invasive FFR-CT or 75580 is performed on the same day as the coronary CTA, use 75580 in conjunction with 75574. Next slide, please. Now, FFR-CT has broad coverage. It's covered by all major payers in the United States, 100% of Medicare, and greater than 98% of commercial payers cover FFR-CT. And you can see on the table on the right, regardless of the payer, whether it's Medicare, with various MAC policies, the commercial payers with Anthem, United Healthcare, Aetna, Cigna, etc., the millions of lives that are covered. And many payers have removed prior authorization requirements for FFR-CT. Next slide, please. Now I'd like to shift gears to CMS payment. Now this is determined by the setting of care. So there's the Medicare physician fee schedule, and then there's the outpatient prospective payment system, or OPPS. Now under the Medicare physician fee schedule, you have physician offices and freestanding centers or diagnostic imaging centers. And the payment rates include both the professional and technical components. Now you also have the hospital outpatient physician component, which is the professional component. Now under the OPPS, you have the hospital outpatient facility component, which is the technical component. Next slide, please. So in 2024, this is the update from the physician fee schedule, or PFS. So for 2024, CMS finalized their proposal to continue the crosswalk they established in 2022 and set a global payment rate of $888.02 for FFR-CT. And this is composed of $853.97 for the technical payment and a $34.05 professional payment. Now, CMS assigned 26.08 RVUs to the technical portion and 1.04 RVUs to the professional portion of CPT code 75580. The professional component of the service includes 0.75 physician work RVUs. Now, the payment for CCTA decreased slightly to a technical payment of $175.24 and a professional payment of $109.37. And you can see the 2024 final rules in the table below with the FFR-CT payment rate, the global payment rate, and the CCTA payment rate underneath at $284.61. Now, the hospital outpatient department updated in 2024, and CMS finalized a proposal to assign the new Category 1 code for FFRCT 75580 to a Level 4 diagnostic test and related service under APC 5724. And the payment rate is $997.22. And this is the same APC assignment as last year and means stable payment for providers. And payment for this APC actually increased 7% compared to 2023. Now, payment for CCTA slightly decreased to $175.24. And in the table below, you can see the FFRCT payment rates for 2024 at, again, $997, and the CCT payment rate at $175.24. Now I'd like to shift gears to the new AMA guidance for 75580 Category 1 code. So this is the new AMA guidance for the Category 1 code CPT 75580, and the American Medical Association released the new coding guidance for CPT 75580 in this document that you can see on the slide, and now it's officially published in the 2024 American Medical Association CPT Codebook, and it's, as stated earlier, available for use as of January 1st, 2024. Next slide, please. So here are some points from the AMA guidance for Category 1 CPT code 75580. So number one, it must augment physician decision-making. So the Category 1 code and described as augmentative software analysis of the data set from a coronary CT. The software analysis is described as augmentative because it provides clinically meaningful output that is predicated on the standard of care for the physician to interpret, end of quote. Now, according to CPT's Appendix S, AI taxonomy for medical services and procedures, augmentative software analysis includes the work performed by the machine for the physician or other qualified healthcare providers is augmentative when the machine analyzes and or quantifies data to yield clinically meaningful output. And this requires physicians or other qualified healthcare providers interpretation and report. Next slide, please. So point number two, report FFR-CT values along the entire coronary tree. Now, once the data are processed and returned to the physician accesses the web-based interactive viewer, and this allows the physician to examine and query the entire model and capture non-invasive estimated coronary FFR values anywhere within the coronary tree. Next slide, please. Number three, evaluate multiple and sequential lesions. So the physician reviews the anatomy and compares it with the estimated FFR model to reconcile discordant data, evaluate multiple and sequential lesions, and determine possible false positive as well as false negative results. Next slide, please. And point number four, determine the location of the lesion with the most significant disease. So this approach allows the imager and the interventional cardiologist to determine the location of the disease burden and the lesion with the most hemodynamic significance. And this allows for a targeted interventional approach that yields the most benefit to the patient. Next slide, please. So in summary, this is the new AMA guidance for Category 1 code CPT 75580. This is published in the 2024 American Medical Association CPT Codebook. And again, it's available for use as of January 1st, 2024. And here are the highlights from the codebook. You must augment physician decision-making. We should be reporting FFR-CT values along the entire coronary tree, evaluate multiple and sequential lesions, and to determine the location of the lesion with the most significant disease for a targeted interventional approach.
Great. Well, thank you so much, Dr. Rabbat, for walking us through that. I know every time the AMA puts out guidance, it's great to have a little more meat on the bones to understand kind of what's required for a new service, but it's also helpful to have somebody break it down for you. And there's been some really good questions that have come through that we'll get to at the end during the Q&A that I'd love to get your perspective on as well. So thank you. So just to give a little bit more color to HeartFlow, and then we'll talk a little bit about HeartFlow's FFR-CT, the HeartFlow analysis. So HeartFlow is a full portfolio company that has 3 FDA-approved products. And this and one is called the Roadmap Analysis, which is commercially available today. And it is a CTA kind of pre-read that allows for reader efficiency and really understanding kind of the whether or not there's stenosis and areas of stenosis on the CTA. We have the HeartFlow analysis, or the FFR-CT, and I'll go into a little more depth on that in the next slide. And then we also have the HeartFlow plaque analysis, also FDA cleared and commercially available, that allows for the providers to understand both plaque characteristics leveraging the CTA images. So really plaque quantification as well as plaque characteristics. And I know this is going to be a huge topic of conversation moving forward. So we're all going to be learning more about plaque analysis together. And, you know, moving on to the discussion of FFR-CT and the HeartFlow analysis, you know, this is one of those technologies that has been extensively studied. You know, there is over 800 peer-reviewed articles on FFR-CT. It is a non-invasive test for coronary artery disease that really allows for an understanding of, for an understanding of the physiology associated with the coronary artery disease to support physicians in their treatment decision-making around symptomatic patients. It's also included in the latest version of the the AHA-ACC guidelines, which were published at the end of 2022 as a Class 2A recommendation for chest pain patients. So this is just a quick overview of the HeartFlow analysis, showing you how you can determine for the billers and coders and admin teams on the webinar. You know, being a policy person myself, I love this 3D model because you can interpret it as well. The red is an area of blockage or bad. Blue and green tend to be good. And as you could see, this interactive model allows you to really understand the FFR values at any point throughout the entire coronary tree, per vessel, per segment. It's really useful in clinical decision making. So with that understanding of, you know, both the AMA guidance as well as HeartFlow's FFR-CT, I want to hand this over to Monica Burnett, and we're going to get a little bit into the weeds about understanding with the Category 1 transition. What does that actually mean for both clinical practice as well as all of the administrative things that happen when there's a code transition? What should you and your billing and coding, revenue cycle, prior authorization teams, what should you really be thinking through, you know, as we walk through this transition? So Monica, can I hand it over to you?
Sure, thank you, Cara. Advanced slide. So we're going to talk about the practical considerations that you need to have as you prepare your systems for code transition to Category 1. Advanced slide, please. Okay, so although we're a little bit into 2024, we still hear some rumblings. There you go. Some rumblings regarding things that our sites are encountering. So one of the biggest things that you want to make sure is that you've updated your charge master and fee schedules, depending on what type of site of service you are, to ensure that you've optimized available revenue as you start submitting new codes. And then making sure you understand the crosswalk of the retired T codes to the new CPT code. So the CPT codes, there's one CPT code, as you saw, that are 4 codes collapsed into, but those codes now may need to be billed with modifier, whereas modifiers for component modifiers were not applicable to the T codes. So in the new code structure, if you're only billing for the technical component, save for if there's guidelines for the health plan that you're submitting your claims to, you may and may not be required to add the TC modifier. If you're in a professional setting or a ambulatory setting, doctor's office, imaging center, you will definitely need to append modifier 26 or TC as appropriate, or bill the global code. So make sure you understand which scenarios are required for your claim submission, and that your system is configured to accommodate those scenarios, as well as your charge master. So one of the important things we wanted to call out is, while 0502T was not reimbursed by governmental payers, it is a component of service that was reimbursed directly by many of the managed care plans or commercial payers. And then also the governmental payers did use that data to set or understand the expense structure. So as you're consolidating your fee schedule down for that technical component portion of your charge master, be sure to factor in the expenses related to 0502T along with 0503T as you set your charge master for that technical component. And as you set your charge master for the global component, the same thing. Make sure you considered the expenses related with that step of 0502T so that you have an appropriate global charge. And then finally, if you're in a facility setting, don't forget to align your revenue code for your hospital outpatient and hospital inpatient sites of service. So again, revenue code isn't a concept that applies to professional claims, but if you're doing any facility type base billing, you do want to make sure you've picked the appropriate revenue code or continue that legacy revenue code with the new CPT code. Advanced slide. The other thing to get ready for or area to ready for is your prior authorization workflows in your conditional order. So starting with the conditional order, again, you want to make sure your orders have been updated to fire off, because oftentimes those orders have CPT code charge messaging attached to them that feed your billing system. So you want to make sure that your order set is properly configured to send the right charge messages over to your new to your billing system. So again, the T codes being deactivated or retired, you want to make sure 75580 with any applicable modifiers based on site of service or what component your providers are going to be billing for has been figured up to send those proper charge messages down to the downstream systems. And your order should be active. We're already past that date, but making sure your order is active for January 1. You want to give your IT team, of course, when you have any of this going on, your IT team should be given appropriate lead time to set those or update those configured systems and any interfacing messages that need to be updated as well. So prior authorization, if we look at that, this is where we're still seeing a little bit of a lag, if you will. With the T codes being retired, it does require a couple of things to happen. The RBMs must update their code sets to reflect the new CPT codes. That generally happens with automation, but there also has to be communication from the health plan to the RBM confirming that they are allowed to provide prior authorization, if you will, support to the CPT codes. That's often done by CPT code assignment. We are seeing some disconnect where there may not be clean communication from the health plan to the RBM to authorize the RBM to manage or continue to manage prior authorization workflows for the FFRCT services. So be sure that you've reached out to the RBMs to ensure that at least for your top payers, they recognize the code and that their systems are ready to accommodate any prior authorization requests. If not, it may require you to engage with your provider rep with that health plan to make sure that in communication with the RBM is tidy and that they update their systems as quickly as possible. Making sure your prior authorization team is also aware that there's a new CPT code that they need to be requesting the prior authorization for. And again, understanding that crosswalk from the T codes to the new CPT code in the applicable modifiers. Most of the RBMs now have removed any requirement that you identify modifiers as you're making the request for prior authorization. So they essentially do a panel authorization and they assume that you're going to bill either globally or one of the component codes. However, that's not 100% true for any health plans that may manage their own prior authorization requests. So just be mindful that your team will need to understand that crosswalk as they're making prior authorization requests for the new code. And then if there's been any pre-scheduled events, which depending on the backlog to get access for your patients to have their CTAs scanned, you may be scheduling far into the future. You want to make sure any prior authorizations that have been previously secured when the T codes were effective, but not yet performed, have been updated to reflect the new CPT code. Again, you would think the RBMs would do that proactively for the provider community, but that doesn't necessarily happen with automation. So you want to protect your revenue, make sure that any pre-scheduled events that have not been performed yet, where the authorization was secured prior to the release of the new CPT code or the activation of the new CPT code, that they now reflect the new CPT code rather than T codes in the RBM's system, so that as your claims release, you don't encounter delays to payment because you're having to appeal any denials that may result. Advanced slide. So the last thing, with the shift in the CPT code and the clarification with the Category 1 codes, we did update, or there should be some updates to your documentation requirements. With the AMA clarification as well, we wanted to make sure everyone was well informed on updates that may be required for your template. So documentation that's key to have in your chart as you're pursuing reimbursement still is a solid history of signs and symptoms consistent with coronary artery disease or confirmed personal history of coronary artery disease that may not be responding to current guideline-directed medical therapy. A signed order should be in the chart for the FFR-CT to be performed as clinically indicated. That is most important for Medicare Part B claims. Medicare Part A isn't as much of a stickler, but for the professional component in any Medicare Part B, that is absolutely a requirement. Documentation confirming that the CTA is abnormal and that therefore the FFRCT is warranted. That should be documented in the CTA impression at a minimum. Ideally, if you can your provider can pull that forward in the indications for the FFRCT interpretation, great. At a minimum, it should be in your CTA interpretation so that as you submit that documentation, you've got confirmation that the FFRCT was warranted based on the CTA results. Reporting the computed FFR values along the entire coronary tree. Again, HeartFlow does provide that analysis in their analysis, those calculations. And so either including that PDF or having your provider include that in their dictation will be critical. Determining if there's any false positive or false negative. So basically that reconciliation of discordant data that should be apparent if it exists in the interpretation report of the FFRCT. If there's any interventional care required or recommended, that should be identified, including identification of the specific lesion with the most disease. Include documentation of how the FFRCT result impacted clinical decision-making. That typically is going to be in the impression section of the FFRCT report. And then also as a reminder, for any Medicare or Medicare Advantage patients, if you're required to produce documentation for your FFRCT interpretation or reimbursement, they are going to be looking for documentation of BMI. Documentation of BMI, if you're asked to upload supporting clinical documentation for a prior authorization request, is also a requirement for Medicare or Medicare Advantage patients in those territories or those Medicare MAC jurisdictions where there is a published LCD. So the published LCDs do still require that BMI to be documented, although it doesn't restrict or have any impact on restrictions for eligibility of FFRCT. So we do like to remind people that it's still a requirement at this time. Advanced slide. And that completes it for my presentation. Back to Cara.
Great. Thank you, Monica. So as you heard from both Dr. Rabbat and Monica, there's a lot to keep in mind with the new CPT code, as well as the FFRCT service. And so, we wanted to let you know you are not alone in this. HeartFlow offers customers reimbursement support to ask one-off questions. We also do extensive billing and coding education. We support optimizing prior authorization workflow because depending on your payer mix, that can look a little bit different. We have a team that engages with payers to really understand and bolster access to FFRCT and now plaque analysis. And there's much, much more that goes into that. And so if you heard anything today and you have a one-off question or you'd like a review, or maybe the charge master was set, but you want to make sure you got everything included, you can just email reimbursement@heartflow.com. That goes directly to our field billing team. We'd be happy to tackle any of those questions. You can also throw those questions into the Q&A. We can tackle them here. But just so you know, I know everybody has slightly different circumstances. We offer full support from a reimbursement perspective to really support you through this Category 1 transition and beyond to optimize your reimbursement workflow for CTA, FFRCT, and then plaque moving forward. Now, HeartFlow is both a full portfolio company, but we partner with all of our customers to really make the most of that CTA first pathway. And we do that in multiple areas. We offer extensive CTA support and education through our CT applications team to really allow for those high quality CTA scans. I mentioned our reimbursement support. We have technology integration to really optimize that PACS, EMR, so Epic or Cerner integration and other IT solutions to make sure that this pathway runs smoothly. On the other side of the screen, and really a true strength of HeartFlow and partnering with HeartFlow, is our education, our medical education, peer-to-peer reviews with physicians to really understand how to utilize and get the most out of the technology and service. We provide extensive education programs beyond that for all components of the CTA and FFRCT service. And we also offer ad hoc case reviews if anything comes up where you really would like another review to fully understand what the results mean, or if there's something that, flags that you didn't quite understand, or there might be a discordant case in there. We offer ad hoc case reviews to really make sure that there are no questions about the FFRCT analysis that was provided. And, with all of that, I know there's been a lot of questions, and thank you for everybody who sent in the questions. We will get through them. I wanted to start off, because there's a lot of questions about this, to throw one to Dr. Rabbat. Dr. Rabbat, you went through the AMA guidance around the new Category 1 CPT code, particularly that it must augment physician decision-making, evaluating across the coronary tree, and really, commenting on areas of high disease burden and multiple sequential lesions. Within your practice over, the past 10 plus years, How do you see those things that are in the guidance really play out in practice, and the importance of them, and really supporting and leveraging these FFRCT results to really optimize patient care, and understanding kind of the benefit of using an FFRCT for those patients who need it?
Yeah, Cara, that's a great question. In regards to its augmentation for physician decision making, we've seen that FFRCT can safely defer unnecessary invasive angiography, for example. Now, oftentimes there's discordance between what we see anatomically and what's going on at the physiology level. And in fact, Kara, if you look at patients who have lesions that are 50 to 70% diameter stenosis, the majority of them would actually be incorrectly identified for stent placement based off of the anatomy alone. So having that information from the FFRCT and the physiology really adds value. Now, we also know from multiple large-scale registries such as ADVANCE, which was a very large prospective, multi-center registry that included over 5,000 patients across the globe. It really validated FFRCT and its ability to augment the physician decision-making. And in fact, for those of us with access to the FFRCT, it actually altered the therapeutic decisions in 2 out of 3 patients. Now, in regards to reporting the FFRCT values along the coronary tree, so FFRCT provides continuous values of FFR in all the epicardial vessels and shows changes in physiology across the lesion as well. So the delta change in FFR, the delta FFRCT. So this differentiates between focal lesions versus diffuse disease, which actually impacts therapeutic decision-making for us as physicians. And in fact, that metric of delta FFRct has been shown to be an independent predictor of revascularization and other cardiovascular outcomes, such as acute coronary syndrome. Now, when looking at multiple or sequential lesions, it really provides lesion-specific physiology information anywhere along the coronary tree, which allows us to understand the location of the pathology, the disease, and better identify and treat the disease, as compared to looking at more of the lesion level information. So I've had many patients over the years, Cara, who based on their CT scan were found to have multivessel disease and were recommended for coronary artery bypass graft surgery. So surgery based off of the anatomic assessment on their CT. But after having the information from FFRCT and the physiology, they were actually downgraded from a more invasive and costly coronary artery bypass graft surgery to a single vessel PCI and stent. And I've been following these patients for nearly a decade now, and they're doing great with this strategy. And I always say FFRCT really acts as a bridge between the cardiac imager and the interventional cardiologist. And it allows us to use the FFR values and the interactive model to determine the appropriate therapeutic management and plan for our patients.
That's great. That's a fantastic detail. One other follow-up is, in kind of the care pathway for these patients, you have both the referring physicians, typically general cardiologists, but at times primary care physicians, as well as on the other end, interventional cardiologists who need to act on findings from the FFR. Can you give a little bit of color to how you document your findings, both in your impression, but also communicate to the broader cardiology community what you see in both the CTA and FFR, and how that can impact patient treatment management?
Sure. So at the report level, so I've really focused more on the lesion over the years, and report on the lesional stenosis, the lesional plaque morphology characteristics, as well as the lesion-specific FFR-CT values. Now, once that interpretation is in, I'll oftentimes, in my clinical practice, I've incorporated the FFR-CT model into our EMR. So prior to my impression and plan for the patient, I'll actually copy and paste the 3D color-coded model into my Epic note, my clinic note, and I'll send that off to the referring physician, whether it be a primary care physician, internist, family practitioner, etc. If the patient requires revascularization, there's a couple things that you can do. Typically, what I'll do is I'll send the PDF or color-coded FFR-CT map to my colleague. There's an application where you can actually get fluoroscopic projections from the web-based interactive model. And so if you can appreciate the lesion best in an LAO cranial view, I'll incorporate that into the report, send that off to my colleague in the cath lab. And oftentimes, many cath labs have incorporated the interactive model into the fluoro suite, whereby, prior to and during intraprocedurally, they can interact with the FFR-CT model prior to revascularization.
Great. I'm happy to hear you use that sort of the images to really communicate back and forth and what's going on. I think that's very helpful. Okay, few other questions. I'm going to switch gears and go over to Monica for we lived in the clinical world for a minute. I'm going to hand a few things over to Monica. One question that came through, and I think we might have the code slightly off here, but how do we know what components of, and I think it should be 0501T, need to be included in the new charge?
How do we, okay, so 0501T is the global charge, which would include all components.
Okay.
0502T was called out specifically because that's not reimbursed. If you look at the Medicare or CMS information or any governmental payer, it's not separately reimbursed. So we want to make sure that component is not left out of the calculation as you migrate over to the technical component. So it's the technical component that you want to make sure remains whole as you consolidate 0502T and 0503T to the new technical component code, which would be 75580 with the modifier TC.
Okay, great. Now, one more question for you, Monica. How difficult is it to get prior authorization and pre-ordering of FFR-CT when you have to document the CTA findings first? So a prior authorization kind of workflow question.
Okay. So how difficult is it to get them at the same time? Is that the question?
It's just the question is, how difficult is it to get pre-authorization and pre-ordering of FFR-CT when you document the CTA findings first, or when you have to document the CTA findings first?
It's not difficult at all if it's done in the proper order. So the RBMs, by and large, do, while they may allow you to request the authorization for both CTA and FFRCT at the same time, they really do require the result of the CTA to drive confirmation of medical necessity for the FFRCT. So if you do, as long as you have that CTA result available, it is completed within a matter of minutes, generally speaking, maybe a couple of hours if you're dealing with Carelon, but Evacor is within seconds, Carelon is a couple of hours, and then NIA is somewhere in between. So not difficult at all, as long as you're able to confirm that the patient has had a recent CTA, that they have an appropriate coronary artery disease diagnoses or, signs and symptoms. If the patient isn't confirmed yet to be suffering from coronary artery disease, and that the patient, that if requested, you're able to upload that CTA interpretation upon request. Very quick turnaround time, very minimal complications or challenges to getting those authorizations completed.
Okay, great. Thank you. One other question that came through that I thought would be interesting to hear is revenue codes are always a question, I think, because CMS has not dictated specific revenue codes. From your experience and kind of how, what we've heard from other sites, what is your recommendation for linking that appropriate revenue code for CTA FFR-CT?
At this time, we're still recommending that you use revenue code 480. That is what well over 80% of the facilities in the country that are live with FFRCT are reporting revenue code 480. Now, we have seen a little bit of noise, if you will, from the Medicare MACs denying claims because the new CPT code does fall within the range of radiology CPT codes, and the recommended mapping for that range is a different revenue code. However, in the CMS manual, it does indicate that hospitals aren't required to follow that recommended mapping. And then also the LCDs, none of them to date have been updated to require a specific revenue code. And if you look at the billing and coding article that accompanies the LCDs in the 5 of 7 MACs where that's been documented, the verbiage regarding the revenue code, since it's not stipulated, indicates that claims should not be denied based on use of a specific revenue code. So at this time, we are still recommending that hospitals stick with use of revenue code 480.
All right. Dr. Rabbat, question for you. You know, we are, let's say, 6 weeks into the new year. You've been performing CTA and FFR-CT with the new Category 1 code. Have you seen any issues? And, you know, what are some things that you worked with your team on to make sure everything kind of translated smoothly?
So I think it's important to have open communication with your team, you know, with your business administrator, whether it be in your cardiology department, radiology department, and clear lines of communication. We haven't seen any issues that I'm aware of thus far in that regard.
That's great. Yeah, and I can say, you know, Monica's highlighted a couple things to keep in mind. We have not seen very many issues. I think the transition has been smooth, and we really appreciate, you know, all of the providers' work in getting ready for this. Every once in a while, there's kind of a payer issue where, you know, an edit wasn't updated. Those are typically taken care of in about, you know, a day, I think, you know, upwards of a week. But we've been able to really allow for a code transition and a service transition from 4 codes down to 1 code in a fairly smooth fashion. So I appreciate everybody who's on this call who's here to learn more, you know, with the AMA guidance. I would say overall the transition has been very smooth. And, you know, the important thing to keep in mind is, you know, how you leverage the service and what, you know, what's documented and communicated out to the broader community when performing FFR-CT. So with that, I think we've tackled all of the questions. I would like to thank everybody for joining. I know I've learned a lot. This has been very productive. Again, if you have any one-off questions, billing, coding, anything like that, please email us at reimbursement@heartflow.com. And I'd like to give a very special thank you to Dr. Rabbat and all of his wisdom today and sharing with us, particularly, you know, those clinical case scenarios were really helpful, and to Monica for sharing those practical considerations, and for SCCT for helping us put this on. So thank you all very much for joining, and we look forward to having future education sessions and having this group join and ask really engaging questions. Thank you.